The first is obviously Restorative Visit One, and this is where we're going to take the preliminary impression. So first, after we put the Optogate in, is to remove these Teflon plugs. This is plumber's tape. We're going to use the endo file, or a bar broach works fantastic. You just spin that a little bit, it'll catch the Teflon tape and take it out of there. We like to use the Teflon tape because it's an inert material. It does a great job of keeping the food and bacteria from getting in the access hole and really protects it. So an alternate method, and we use this as well, is to take an explorer tip and a little cotton pliers. You snag the Teflon tape, it'll pull out usually in one big long strand. The assistant will grab the plug with the cotton pliers, and now you have a nice clean access to the 4 screws holding the temporary prosthesis in. Okay, so next part, you have to unscrew the prosthesis. Sometimes, depending on the access, you might have to fumble around a little bit to catch the head of the screw. But most time you can untighten these just by finger pressure. If you need to get the torque wrench in there, give it a little nudge. That's perfectly fine too. And as these loosen, sometimes you'll see the screw will come out with the screwdriver, which is fine. Just put them in a little dish. Make sure you don't lose those. A lot of times they'll stay in the screw channel. And the important part there is to let the assistant know which ones have the screws in the screw channels and which ones don't. Also, a very good idea to have a provisional screw on hand just in case you lose one. They are really tiny, these screws. Okay, in just a second we'll have the 4th one ready to go. And very important, when we remove the prosthesis, we don't want to turn it upside down to where the screws can fall out. Obviously they'll end up on the floor and you're going to have to hunt for them. Okay, and we're ready to go.
So the first thing I like to do once the prosthesis comes out is go ahead and wipe the tissue with a 4x4 with some chlorhexidine in it on there. That'll help with the taste and the smell coming out of underneath the prosthesis.
And then you'll see the prosthesis is fairly clean. Sometimes if they're not cleaning, you're going to have to debride that a little bit. Okay, then the next, and this is probably one of the most important parts of today, is the torque test. And the reason this is important is you want to make sure the abutments are fully seated, and you want to test to make sure the implants are fully integrated. Now in this patient, you'll see the back 2 have the angle correcting abutments there. So here we're utilizing the screw that holds the abutment to the implant. And once we have the screwdriver catch on that, we're going to torque that up to the full 25 for this system. And we don't want to see any movement. If perhaps those abutments were loose, this is the right time to tighten them down, because everything downhill from here needs to have those abutments very secure. If they are loose at this stage, they're only going to get looser later, and that's going to lead to inaccuracies, not just for the provisional, but for your final prosthesis. Okay, in the anterior, we went straight to fixture in this case, and so we're going to use the impression coping to do the torque test, and obviously it'll also be the impression coping for our preliminary impression. And these we'll finger tighten to start with, and then we're going to torque those up to 15. And again, here we're just testing to make sure that the implants are stable. We'd rather find that out at our office than at the restorative dentist office. Okay.
And I always recommend this to all my prosthodontists, periodontists, and oral surgeons out there, because we are more capable of dealing with a failed implant, let alone having one of our restorative colleagues actually have to deal with the failing implant. So I recommend this to all my specialists to please torque test all the implants before we send them to our restorative colleagues.
Right, and this brings up a good point. If there is what we'll call a spinner, a failed implant, you have, let's say, 3 other integrated implants. So if this is happening in your office, you can just tighten the prosthesis down to the 3 stable implants, send it off to the surgeon. Obviously inform them they can deal with that. Usually it amounts to taking out the failed implant, replacing one of the implants, waiting the 2 or 3 months, and then proceeding just as we are here today. Okay, so we just about have these all torqued in and tested. In the anterior, as we said, these will also be the impression copings. But for the posterior, we'll still need to tighten in a couple of impression copings.
Now, a lot of you are out there saying how accurate is a closed tray impression. For this prosthesis, it is very inadequate. But what we're going to do is be making a custom tray and an impression jig on the second appointment. So this is with the closed tray impression, we could send it to the lab, and then the lab could go ahead and make that acrylic bar for you.
Okay, and these the impression copings going in. These again closed tray, they come in short and long. We prefer to use the long ones. Main reason for this, if they're the short ones and there's significant tissue depth, you're not going to pick up much of the coping, and the impression and the resulting model will be that much more inaccurate. These are just strongly finger tightened on. They get a little slippery because they're not knurled and there's not a screw access on them. So you just want to verify that those are very tight and accurate. At this point, we're ready for the preliminary impression.
And we're going to be utilizing the same jig we used the day of surgery to place the abutments and help the surgeon place the implants. So what we're going to do is try that in and make sure our jig is not hitting any of the impression posts. If they are, you're going to want to relieve those on the acrylic stent. So right after everything's passive, everything looking good, you want to go ahead and butter it up with your favorite GC America polyvinyl adhesive. Then you're going to go ahead and give the operator the light body with a cut-off tipped syringe. Now the product we're going to be using today is GC America's Excellence, and right now you're seeing the pink, which is the light body. The light body it's a fast set, and it has a set time of 3 minutes and 30 seconds. While the assistant is going ahead and load up that clear stent with GC America's Excellence Heavy Body Rigid. The reason I like the rigid is because you're going to get that confirmed snap when you're putting that closed tray impression coping back into the impression itself. So here you go. You're seeing you want to not be frugal at this point. So go ahead, because the assistant's going to need some time to fill that tray up. So go ahead and express as much as needed. And then when that's done, go ahead and place the clear jig back in the mouth and go ahead and take a tongue depressor, wipe out the excess. And once again, here you go with the OptiGate. It's real easy to pull the tab and then go ahead, take the OptiGate out, muscle trim. And even though it's a preliminary impression, I recommend muscle trimming for all impressions. So since it has two different set times, we're going to wait for the longer set time, which is the light body, the 3 minutes and 30 seconds. But once the timer goes off, go ahead and remove the initial impression. With a nice snap, comes out, inspect the impression, make sure the patient's doing okay. Everything's looking great.
Okay, now at this point, the impression's done. Again, preliminary impression. We're just going to remove the copings. Sometimes, again, you can't do it with finger pressure. You'll need to get the torque wrench, give it a little nudge, and then those will just spin out under hand pressure. All of this should only take about 30 seconds to a minute. Very simple, very easy. Now in the meantime, the assistant has taken the provisional to the lab, and she's been cleaning that, tartar and stain remover if need, and into the ultrasonic. If the patient is having a problem with the hygiene, they're instructed at this point also. So it's a good time to take care of the oral hygiene measures during the downtime. Okay, again, we're going to remove these closed tray impression copings from the back. Depending on how firmly you had those tightened on there, they can be a little slippery. Here we don't have a lot of tissue depth. So the important part there is there's not going to be much contraction or collapse of the gingival tissue. If there was significant tissue depth, you want to remove these copings and have the prosthesis ready to seat within seconds. If you wait 4 or 5 minutes, that tissue could contract just enough that it gets very uncomfortable for the patient to have this back in there. And you might have to spend a few minutes relaxing the tissue, compressing the tissue, before you can screw this back in. But here we've gone directly to there. We're going to hand tighten the first few. You don't want to take the first one down all the way in case there's some inaccuracy in how you've seated it. So just finger tighten those, move to the next. And finger tighten. And again, you can see this only takes a minute or so, maybe a couple minutes at the most. Sometimes you may have to fumble a little bit to find the seating of the screw, but once it's engaged it should take just a few turns and a few twists, and then you see we're engaged. And the final one. So again, finger tighten now, and then we'll take the torque wrench and you bring these up to just 15 Newton centimeters. It doesn't seem like very much torque. It doesn't need a lot of torque. You don't want to go much beyond that because again these are very tiny screws and you risk either snapping the screw or stripping the head. Very difficult to retrieve the screws if you strip the head. That's a very narrow channel that you're working through. Again, just up to 15 Newton centimeters. The prosthesis holds very nicely. It's a very stable prosthesis. Also notice that the finger is on the top of the screwdriver. That allows the torque wrench to rotate around that axis. If you hold that off axis, again with these tiny little screws, you may dislodge the screwdriver and damage the screw head. And just verifying that it's to 15. Very good. All right, so prosthesis is torqued in. And the final step is to repack the access openings. And there's a variety of ways this can be done. One way is just to take a perio probe or an amalgam plugger, an endo plugger, and gently feed that into the area. You can use the tip of the cotton pliers to do a final compacting. An alternative method is to roll the tape in your fingers into a narrow little cone and place the cone in there and then compact it. It should be compacted though. If you just roll a little bit and you don't have an intimate seal, the food and the bacteria can still percolate through. Least of the worries would be that you get a little food and bacteria in the top, but if it works its way down to the screw access and occludes that, you're going to have a tough time clearing that so that you can get the screwdriver on. So you want this packed in reasonably tight. You can see how quickly that can go. We left the right front one a little long. You'll see how we take care of that in case the assistant's cut a fairly long piece of Teflon and doesn't all pack in there. So we're going to come back to that one. The rest of them are going in nice and easy. We're occluding the access hole very sufficiently.
Now you're also going to want a longer piece of Teflon, let alone multiple short pieces, because when you go to take them out and the next time you might think it's all out, but there's actually another small piece of Teflon on there. So I would say go a little longer and go ahead and trim like we're doing right here, than leaving it short and just packing multiple short ones in.
Correct. So here we cut the excess off as close as possible, and then that last little remaining part will be compressed and compacted into the access. Now at this point, you could seal that with composite if cosmetics is a big concern, but this is going to come on and off a number of times. We prefer to leave those open so you don't have to take the high speed to get at the access. Okay, and so she's ready to go. Optic gate off. End of restorative appointment 1, preliminary impression. And on to restorative appointment 2.